My talk is actually about neuroangiographic anatomy, and so I'm not going to get into a lot of the detail, and a lot of nomenclature may be similar, some of it may be different from the surgical anatomy. So whenever I see something in an angiographic book, and then I look at something that Roten writes, sometimes there are differences in there. So just keep in mind this is from the angiographic perspective. I will breeze through this because this covers essentially all the cerebral anatomy, and as you just got the posterior circulation, a lot of that is actually in this talk. You guys can review the YouTube videos and see the whole slide deck, but I will probably breeze through the last half of this. So there's a disclaimer. These are books. I just checked yesterday, and it doesn't look like there's a third edition yet for Osborne, but Osborne's a very good primer for cerebral angiography, different positions for the eye and your fluoroscopy. Pierce Morris is a pretty good book, and then obviously Berenstein, which is a good Bible for variants, angiographic variants, and embryology as well. So as you guys all know, angiography is really based on fluoroscopic X-ray using ionated dye, and now with the advent of digital subtraction, what it does is it takes a snapshot still before you inject the dye, and pixel by pixel will subtract that, knowing that that's in the background, and then the dye itself is all you see. It's subject obviously to the density of material that the fluoroscope, the X-ray is actually penetrating, so the computer knows or doesn't have a good way of differentiating when it has to penetrate the skull base, for instance. It subtracts harder. So whenever a vessel, as you'll see as I get into the ICA, as a vessel is going through skull base, it actually subtracts a lot more, so it's actually difficult to see the vessels sometimes that are running through a lot of bone. We have the ability to road map, which also takes a snapshot of the injected dye and then inverts the grayscale, so you're actually looking at bright on white, and then that allows you to see your wires and catheters superimposed over a white background. The projections that I'll talk about today, I often refer to AP as your frontal view, but when we talk about anterior circulation views, the true AP view is really more of a Townes view. So you're actually bringing the orbits down closer to the foramen magnum, and the reason for that is you're trying to bring the ophthalmic artery off the ICA. So when you're talking about ICA, most people will just say AP, but really they mean a slight Townes view. The straight AP view or transfrontal or transorbital view is useful really for looking at the basilar trunk. That's a view for that. Townes, again, you're angulating down, and steep Townes is really useful for looking at your PCA and as it wraps around the midbrain. Waters and submental, if you want to look at the anterior communicating, oftentimes the submental and slightly oblique view lays out the anterior communicating well. With the lateral view, not a lot that I'll do with that. Straight lateral, you'll try to center the isocenter, the region of interest, and as much as possible into the middle of your field. Whereas if you're looking at vessels that are superimposed, the Schuler's view is actually useful. So you're actually shooting, for instance, this way, if you're trying to get the PCAs off each other and trying to see which of the PCAs of interest you want to focus on. RAO and LAO, anterior oblique, right or left anterior oblique, and those are useful views for ipsilateral for MCA or ipsilateral for the carotid bifurcation. And then 3D rotational angiography, which takes about 120 still images, and then the computer stacks them together and gives you a data output that you can actually manipulate and play with. So that's actually changed the safety and of what we do for interventional radiology. These are the things I'm going to cover. Like I said, I probably will breeze over the posterior circulation. Starting at the cervical carotid, the carotid bifurcation typically is the best view as in this picture here, an ipsilateral anterior oblique view. Sometimes you maybe come down a little bit submental, but that's based on the fact that the relationship between the ICA and the ECA at the bifurcation is that the ICA takes a posterior and lateral approach, typical course. The bulb itself for about first 2 centimeters or so will be dilated, and that's important for measurements where the bulb typically is the vessel that's involved with ICA stenoses. So when you do NASCET calculations, you want to remember that you don't want to compare it to a normal bulb. You actually want to compare it to the ICA distal to that, and that's how the NASCET criteria are calculated. Anatomic variants, there's tonsillar loop. Here's the picture in this, this older angiogram. Does actually take a medial course of the ICA. Let's see if I can. I don't think that works. Takes a medial course, and then as it, oftentimes it will have a true chicane where it's actually making two 180-degree turns. And when it lies very medial in that situation, it's called the tonsillar loop. And it's important when we're thinking about access and how our access catheter is going to give us support. That tonsillar loop sits behind the tonsil and it can often manifest as a pulsatile mass. So prior to this, ENT people would biopsy a pulsatile mass and actually get into the ICA. Variants, Shane actually talked a little bit about carotid cave, and so this will actually enter the discussion here. So there are really two different nomenclatures. Osborne really breaks it down into, or actually the common nomenclature is really just looking at four. There we go. Four different segments, starting at the cervical, as you all know, originating from the bulb, and then as it gets to the skull base, enters the skull base, it then becomes a petrous segment. And that petrous segment is then separated from the cavernous segment, so the petrous segment actually then takes a anterior and medial bend genu. Then again, it takes a more vertical genu, and as in that vertical segment, it separates from the cavernous carotid artery via petrolingual ligament. That's really kind of just, if you take that vertical segment and you divide it in half, that would be the distinguishing segment between the petrous and the cavernous segment. The cavernous segment then continues vertically, has a posterior genu, and in that posterior genu will usually make a fairly anterior only turn, whereas then the horizontal segment, and then it enters a siphon, and then at the clinoid segment, past the clinoidal segment, then becomes the supraclinoid ICA. Osborne does break it down into a few more segments, which I don't find entirely useful, but they are descriptive. It does have a cervical and petrous segment that are the same. There's a short segment of the lacerum where actually the carotid passes through foramen lacerum. The cavernous segments are the same. And then the supraclinoid ICA is broken down into the clinoidal segment, the ophthalmic segment, and the communicating segment. And those are defined by the originations of the arteries themselves, the ophthalmic artery and the posterior communicating. So here's a picture of those different segments. You'll see the bulb, which has that initial dilatation. I love this pointer, by the way. It comes up, and then the area where you can actually start identifying the petrous segment is where I remember how I was saying the computer actually is doing some subtraction. And so because it enters the skull base and has to subtract a lot of bone, the density of the ICA seems to be a little bit less, and that's usually will help you denote the entry of the petrous segment. Here, because this is a lateral view, it looks like it's just taking an anterior turn, but in fact it's actually going both anterior and medial, and this is that posterior genu of the petrous segment. And then in the vertical segment, that's where, if you were to divide that in half, that's where the petrolingual ligament would exist, and therefore divide the petrous segment from the cavernous segment. And then there's the posterior genu of the cavernous carotid. Important branches of the internal carotid are the ophthalmic, the posterior communicating, anterior choroidal, and they always exist in that order, with a small caveat that the ophthalmic artery embryologically develops initially both from the ICA and the external branches, so those two come together and fuse, and where they fuse actually determines where the ophthalmic artery originates from. So you can actually, it can originate and the secondary vessel can regress where it's actually originating from the ACA, and that's called a ventral origin of the ophthalmic artery, or it can be much lower down the internal carotid artery in the cavernous segment, and that's what's called a dorsal origin ophthalmic artery. A couple of variants that are commonly talked about, but really are actually not as common as as I might make them sound. The aberrant course of the ICA is that when you're shooting your lateral ICA or you're looking at a temporal bone, you might actually notice that the carotid canal is more posterior than it should be. And the reason for that is as the aberrant ICA originates, the C2 hiatal segment, which gives rise to the internal carotid artery elements, it doesn't. It originates actually from the remnant of the inferior tympanic artery. So that inferior tympanic artery typically doesn't, regresses and it becomes a branch of the ascending pharyngeal. But in the persistent or the aberrant ICA, that remnant remains, and so as it ties in with the ICA, it sits in a very, very posterior segment of the temporal bone. So it sits a good 1 to 2 centimeters posterior to the normal course. It really doesn't have any relevance in terms of pathology, but it's important to notice when you're looking at your temporal bone. The persistent stapedial artery is an artery that originates and can also be located if you look at a temporal bone and you realize that the foramen spinosum is missing. The middle meningeal artery does not originate in its normal course, and it actually comes off of the internal carotid artery. And so the middle meningeal supply arises entirely from the internal carotid in that situation. It's called persistent stapedial because as it makes that course, it runs behind the stapes. I forgot to mention in the aberrant ICA, the inferior tympanic artery then connects to the carotid-tympanic artery, and that's how the external and the internal then form the internal carotid artery in whole. So that carotid-tympanic artery is an important branch because it's essentially a vessel that regresses but can show itself again. It usually originates in the petrous bone. It can show itself if, for instance, a fistula exists, then that artery may actually grow. I won't talk too much about the persistent arteries because Shane talked about it, but if in this situation you're looking at this is actually an MRA, and it looks like a pretty normal looking posterior communicating until you take a closer look at it and you realize it's actually originating from the posterior genu of your cavernous carotid artery, not at the supraclinoid segment. And as he mentioned, it can tie in to any part of the vertebral-basilar system, usually at the more cephalad portion, so into the PCA, into the basilar, or we've actually seen them tie into the AICA as well. Aneurysms can originate anywhere outside of the supraclinoid segment, and a lot of times they don't necessarily need treatment. But if they do tend to grow large and erode the bone, they can cause symptoms, as we recently saw a patient that had a large petrous ICA, and the patient presented with diplopia because the aneurysm eroded and then started compressing the Drell's canal. But oftentimes the petrous aneurysms can be left alone. As they get higher, even if they're in the cavernous segment, they can then produce cavernous sinus symptoms. So a large cavernous aneurysm, if it arises in the posterior genu, it's more likely to compress the Gasserian ganglion. You may actually have trigeminal symptoms, or anywhere along the horizontal segment of the cavernous, as it compresses the cavernous sinus, you may actually have diplopia as well. So those would be reasons that we would intervene upon a cavernous aneurysm. Moving a little further, we talked a little bit about carotid cave, and that is a good debate. I was always taught, Fernando Vinuela said that in the carotid cave, if there's a chance that it could actually be supraclinoidal or in the subarachnoid space, then it should be treated. And typically the relationship of the carotid cave is, as Shane mentioned, medial and at the level of the distal ring. In this picture, and it's actually very important to look at the takeoff of the ophthalmic artery. So if it is medial and it is at the level of the ophthalmic artery, that really is, in my terminology, truly a carotid cave aneurysm. If it's set behind it, then it becomes a superior hypophyseal. And typically the superior hypophyseal and medial, or the carotid cave, are often confused because they both point medially and they both point inferiorly. But I think that the relationship to the level of where the ophthalmic takes off is really the best way to kind of differentiate the two. People call the superior hypophyseals, and there's really kind of a unanimous agreement that that's actually in the subarachnoid space. So if you start using the term carotid cave, you might find yourself trying to debate whether or not it is truly intradural or not. So back in this picture here, if you look at where the takeoff of the ophthalmic is, the ophthalmic, it arises more proximal to it, so this would actually be a superior hypophyseal, or at least I would term it as superior hypophyseal. Same thing goes here. There's obviously a larger MCA aneurysm, but this is a picture of where I would think normally the projection of a carotid cave is, which is both, like I said, inferior and medial. Here's a picture of an ophthalmic aneurysm, and so the ophthalmic aneurysm, there are subtypes of ophthalmics, but usually in that they're not defined necessarily by the ophthalmic artery itself, but by the ophthalmic segment. And for relevance for intervention, the type of ophthalmic artery is relevant. So if it's a type 1 where the ophthalmic artery arises completely separate from the aneurysm, those tended to do well and not have complications from vision loss. Type 2s originate with a kind of a concurrent base where the ophthalmic itself tends to arise from the base of the aneurysm, and then type 3 where the ophthalmic artery itself arises from the aneurysm, and there's really no way to preserve that, at least endovascularly. If the aneurysm arises a little further, a little bit more posterior and tends to point laterally, those aneurysms I will term a para-ophthalmic aneurysm. But most ophthalmic aneurysms, because of the relationship to the ophthalmic artery, typically arise and point superiorly. Ophthalmic aneurysms can get actually fairly large, and they can, like anterior communicating aneurysms, present with vision loss because of compression of the optic tract or the chiasm or the nerve. Here's a posterior communicating aneurysm. And they can arise. They probably have a similar morphology to the ophthalmics that I mentioned. Either the communicating is completely separate, or it arises from the base, or it actually is incorporated into the aneurysm itself. Here's a good picture of a patient with both a posterior communicating and an anterior choroidal. You can see those two actually lie very, very close to each other. I'm not going to go too much into fistulas, but the cavernous carotid fistula really is kind of broken down into both an indirect or a direct. Then the indirect is really another term for a dural fistula, and really behaves very similarly to a dural fistula. So it's important really to interrogate the external carotid artery, because the majority of these will actually get supply from the external carotid artery as well. So if the fistula is actually the shunt lies in the dural lining of the cavernous sinus, the internal carotid artery does give off some meningeal branches, and those meningeal branches, as we mentioned, are the inferolateral trunk and the meningohypophyseal trunk. So those two can opacify the cavernous sinus very quickly, and it's very hard to distinguish whether or not if it's a high flow shunt, whether or not it's truly coming from an ILT or an MHT versus a true rent, where somebody has a cavernous carotid aneurysm and it ruptures, and then you have a direct shunt from the ICA into the cavernous sinus. And because of the fullness and the pressure within the cavernous sinus, you can actually have compromise of the cranial nerves and a cavernous sinus syndrome. So there's a very large cavernous carotid artery probably presenting with diplopia. Ophthalmics, like I mentioned, they can grow very high, and if they grow medially, they can get very close to the chiasm. Anterior choroidals are actually unique, and they're difficult because sometimes they do originate from or share a common origin from the anterior choroidal itself, and so the risk profile might go higher if you have no control with endovascular treatment. You can cause a significant hemiparesis. The anterior choroidal, as you guys know, it has a supply that will supply both the internal capsule as well as a periventricular space around the anterior choroidal fissure, as well as terminate into the epithalamus and supply the geniculate bodies. But usually the geniculate bodies, even though it's classically described, the anterior choroidal syndrome and classically is described as a sector involving a sector nuptia, typically that's in the common anterior choroidal infarcts. You don't actually see that because there's collateral zones from the posterior lateral choroidal arteries. But because the anterior choroidal passes through the choroidal fissure to enter the temporal horn, you can have an anterior choroidal aneurysm that ruptures, and you can have isolated ventricular blood, specifically in the temporal horn when they initially present, and really have very little to none in terms of subarachnoid hemorrhage. And there's a picture of a patient with an anterior choroidal that ruptured. And there's an infarct of the capsule in a patient that was coiled and had a complication, an occlusion of their anterior choroidal. Posterior communicatings, they can have perforators that arise from them, typically from the anterior side of them. If the posterior communicating decide that you wanted a sac or it involves a posterior communicating and there's a big enough P1 segment on that ipsilateral side, and you go forward with coiling that aneurysm, if you occlude that posterior communicating, usually the posterior to anterior flow is enough to supply those perforators. But the more anterior, there's more watershed that communicating will be, and the more anterior the posterior communicating, the more likely the anterior and ventral portions of the thalamus are going to be at risk. It's a picture of the different locations of where we can find aneurysms. I'll kind of skip through that. We talked about the proatlantal arteries and the persistent arteries, so there's just a picture of a nice proatlantal. The ICA terminus, aneurysms arising from the ICA terminus, if they are large and they abut the anterior perforated substance, they can actually have ganglionic disruption, and people can have chorea, or they can have bradykinesia, or even Parkinsonian features that tend to be atypical and really kind of hemi-Parkinsonian if they get fairly large. The ICA terminus aneurysms as well, they put at risk those perforators that do go into the anterior perforated substance. So the ventral ganglia can be at risk for infarct if those perforators are occluded. I'll talk about the segments of the ACA and the MCA. We'll just focus on that in the interest of time. So the frontal view is actually a good view for the A1 segment. So it's usually at this point running both medially and anteriorly. But as you can see from this picture, the A1 segment coming off the ICA terminus, really you see that on full view. This full view is actually also useful to see the recurrent artery of Huebner, which usually arises post-communicating as an A2, because all the ACA, all the rest of the A2 branches are running more in a vertical fashion, whereas the recurrent artery of Huebner will run medially and posteriorly towards the basal ganglia. A2 segment and A3 segments are best viewed from the lateral view, and those are termed post-communicating in the cortical branches. And I know Rotan talks about 6 different segments of the ACA numbers. From the angiographic perspective, the 3 segments are the most important to remember. The A1 on the lateral view is going to be actually very difficult to see because it's actually running, like I said, both medially and anteriorly, to somewhat superimpose on itself. But then it becomes an A2 segment, or the post-communicating segment, where it will run fairly vertically, hit the genu of the corpus callosum, and then become the A3 segments. The A3 segments then are then broken. Let me see if I go. So the A3 segments then can break down into the medial frontal branches, which are also called the medial frontal candelabra, and those medial branches are typically trifurcation, so an anterior medial and a posterior, and then a callosal marginal typically will end in the precuneus, and the pericallosal artery will wrap around the callosum and help supply the posterior splenial artery, which is the collateral zone, collateralizing with the posterior splenial artery of the posterior cerebral artery. A couple branches and variants, medial lenticular striates, going back to the frontal view, or the slightly Townes view. The ICA terminus, the M1 and the A1 supply a very rich zone of perforators to the lenticular striates. So there's a lot of variability on whether or not somebody actually has the majority of their lenticular striates originating from their medial, their lateral M1 segment. Oftentimes they can actually even originate from the A1 segment. So some component of the A1 will actually give rise to the more medial and more anterior components of the lenticular striate body. Splenial branches I talked about, callosal arteries. Azygos, a true azygos ACA is actually a common trunk ACA, not an A1 that gives rise to both A2s, because that azygos is going to be more because of some abnormality in embryologic development. There's a higher association as well with aneurysms. But when you have an A1 that does give rise to both A2s and you have a hypoplastic A1 on the other side, those patients are also more at risk for developing anterior communicating aneurysms because all the flow going into both A2s is being derived from one A1 segment. And the recurrent artery of Huebner I talked about. And either a straight frontal view or a ipsilateral anterior oblique Townes view is useful in that. Interesting syndrome is if you occlude an ACA proximally and you're taking out both the recurrent artery as well as distal coracle branches, as you know, the ACA is going to supply the territory to the legs. The recurrent artery Huebner can actually supply the genu of the corpus callosum, which is really those coracle bulbar fibers. So you can actually get a facial weakness with a leg weakness, sparing the arm. 4 branches of the MCA, M1, 2, 3, and 4, often termed the sphenoidal branch, the insular branch, opercular, and cortical. And MCAs are, the cortical branches are the best viewed on the lateral view. So this is a great picture to show you all the different MCAs, whereas the frontal view or the Townes view gives you a good layout of really the M1 segment. And that M1 segment here is a good example of how those lenticular striates can be so variable. So you have some of those lenticular striates originating from the ICA terminus, and then some actually coming from the really, really far lateral segment of the M1. So this is actually the sphenoidal as it's running over the bone, or horizontal segment of the M1. And then you can see all these M2s as they're hugging the insula, lying in deep in the sylvian fissure. They're lying together, and you can't make those vessels apart from each other, so you actually have to move the lateral view as well. The third segments, so this segment, as it courses up and hugs the insula, all of those branches actually are responsible for giving perforators to the insula themselves too. So if you identify an insular infarct acutely, you need to be highly suspect of an M2 occlusion. So accessory and duplication of the MCA, usually the duplication arises from the ACA. So you'll see an artery that arises from either the A1 or more recently I've seen a couple branches from the A2, where it then courses down kind of on hugging the sphenoid, running alongside the M1, and it may or may not even give off branches to lenticular striate. So it's almost like it is truly a duplicated MCA, and then it runs up and gives a terminal supply to a coracle branch. And between the two, they don't really mix. As opposed to an accessory MCA where a branch may actually originate off the ICA terminus, usually posterior to or distal to the anterior choroidal origin. Here's a good view of the MCA in that there really is very hypoplastic A1, so the ACA is not being superimposed. So if you imagine a triangle here, this is a lateral view of the MCA is a view of what's called the sylvian triangle. If you draw a line from all these arteries actually hitting something, that's actually the roof of the sylvian fissure. And so that's a transition from an M2 branch segment into an M3 segment. So it's hitting the roof of the sylvian fissure, wrapping around the frontal operculum, and then coming out of the sylvian fissure itself into these coracle branches. So this triangle moving from an isosceles triangle moving from anterior to posterior, and then it's larger anterior than it is posteriorly. That sylvian triangle is an important identifying landmark. The apex of this isosceles triangle from which the angular artery arises is the best way to identify the coracle branches in order. So that angular artery, counting posterior to anterior and in the sulci, are the coracle branches that run through there every 1 to 2 centimeters. So anterior to the angular branch is usually the posterior parietal, then the anterior parietal, then the postcentral. So the postcentral being lying in the postcentral sulcus supplies the postcentral gyrus and the accessory sensory cortex posteriorly. Then there's a central artery and then the precentral artery. So the Rolandic or central artery then supplies both the motor strip anteriorly and the sensory strip posteriorly. The precentral artery starting to get some supplementary motor area, and then there's also a lateral candelabra akin to that medial candelabra I told you about from the ACA. That lateral candelabra is also referred to as an opercular branches, and those usually are anterior, middle, and posterior. we'll breeze through. We talked about vertebrals, vertebral segments. We talked about those, or at least Shane talked about those. From an angiographic standpoint, when you're looking at pica anatomy, you have those medullary segments, as we talked about. It makes a tonsillar loop, and it reaches an apex somewhere close into the obex, and that is called the choroidal point. From that point, that's usually where the supply to the floor of the fourth ventricle arises, and those perforators are very important. So if you have an aneurysm or an AVM beyond that choroidal point, it's usually safe or safer to take without having somebody have a pontine infarct. And as Shane also mentioned, the AICA and pica really kind of go together. So it's probably about 1 in 4 people will have a pica that supplies both the inferior cerebellum as well as a lateral cerebellum, and that's termed a pica-AICA complex, or an AICA that then supplies a pica complex. So usually in that view, really the more frontal or transfrontal the view you get, looking at the parenchymal phase is the best way to identify how much of the cerebellum each of that AICA or pica are supplying. So if the pica territory comes from the AICA, that we term that an AICA-pica complex. The other thing to keep in mind is that the pica, an ipsilateral pica, can supply both hemispheres. So there's a lot of splitting of hemispheres and vascular supply, but for some reason the pica can actually supply bihemispheric territory. Here, it's just to kind of follow on to Dr. Tubbs's talk about the segments of the PCA. I mentioned that the steep towns is actually a good view for looking at the cortical branches of the PCA, and here's a good example of that, in that you can actually see both the P1 segment, so the pre-communicating segment, and then there's that peduncular segment that he talked about, but the peduncular and an ambient segment. So you can imagine that there's a midbrain here kind of looking at an angle, and this P2 ambient segment is, as he said, broken down into both a peduncular and a ambient segment. And then the P3 segment being the collicular segment or the quadrigeminal segment, because this is where the quadrigeminal plate or the tectum lies, and that's the spot where the PCAs lie the closest. And those are the terms for the branches, and the calcarine or the cortical branches. Another important cortical branch to be aware of is that oftentimes there's a branch that arises from the P2, P3 segment that runs laterally and inferiorly, and that inferior temporal artery then can supply both the inferior temporal pole as well as the inferior temporal gyrus. And that's a rich collateral zone with the infrasylvian branches of the MCA. I think that's about all I wanted to talk about. He did talk about choroidal branches. Again, the P1 or even the basilar tip, very proximal P1 or basilar tip, those posterior medial choroidals are important, and those will actually run anteriorly and superiorly, supply the choroid lying in the third ventricle, but as it does so, it also has very critical supply to parts of the midbrain, and then the posterolateral, which tends to originate from the P2, sometimes P3 segments, going through the choroidal fissure, running laterally, supplying the choroid out into the choroidal fissure in the atrium, and as it does so, it supplies a lot of the ventricular supply. And so having a proximal PCA occlusion, you're not just going to get an occipital infarct, you're usually going to get a lot of periventricular infarction, usually in the temporal lobe. The more anterior is going to have more infarct, as well as areas of the uncus, and as it's passing because you're infarcting the posterolateral branches, choroidal branches, as they're passing through that choroidal fissure.